Hello everyone, I am Dr. Anna Buckler, a GP with an extended role in paediatrics. I work as a salaried GP in Edinburgh, and I also have a role within my cluster doing outpatient medical paediatric clinics alongside a consultant paediatrician. I wrote this article on managing primary headaches in children, as it's a presentation we see often in GP and in secondary care clinics. Headaches can have a significant impact on children's school attendance and quality of life. I hope to give GPs the knowledge and confidence needed to manage the majority of cases in primary care, with the focus of management being on addressing lifestyle and psychosocial factors. In this podcast, I will summarise the key considerations when taking a history, examining and managing a child with a headache in primary care. So starting with the history, although in the majority of cases there will be no underlying pathology, when a child presents with a new or changed headache, it is important to rule out red flags. One of the things to consider is raised intracranial pressure. Red flags or signs that may give light to this would be waking through the night with a headache or present on waking, aggravated by increased pressure such as sneezing or bending down, recurrent and or early morning vomiting, and with an infant, there's a setting sun sign where there's failure to upward gaze. Any of these signs would need an urgent same-day referral to the emergency department. Another consideration would be space-occupying lesion, and red flags that may be signs of this would be a child presenting under the age of 4, a teenager with a constant headache, recurrent and or early morning vomiting, wakens through the night with a headache, progressing headache, altered personality behaviour such as acute aggression or deterioration in school, and then any associated neurology such as ataxia or a new strabismus. For some of these red flags, you may want to do an urgent outpatient referral to neurology, and for others, they may need to be seen that same day in the emergency department. Then you always have to consider intracranial infections such as meningitis and encephalitis, and red flags for those, of course, would be fever and signs of meningism such as photophobia or neck stiffness, and they would need urgent same-day referral to A&E. And then finally, if there's been a traumatic head injury within 5 days of the headache, and then you need to consider traumatic intracranial bleed, and that would be a referral to the emergency department that day. Another thing to be aware of is that primary headaches do not alter growth, development, or puberty. If there are concerns, it's important to consider intracranial or secondary causes and refer to medical paediatrics or neurology depending on your local pathway. Once you have ruled out the red flags, you can focus on eliciting information about the characteristics of the headache. And so there is some overlap in terms of characteristics of tension versus migraine headaches, so it may not always be easy to distinguish between them. However, most of the management principles are the same. A helpful question to ask is, what do you do when you have the headache? If the child goes pale, feels nauseated, and has to lie down in a dark room, this is more suggestive of a migraine, whereas a child who takes Calpol but continues to play is more likely to have a tension-type headache. Or, of course, you must consider medication overuse headache. Cluster headaches are very rare, and they would present with a very severe unilateral headache with ophthalmic symptoms such as a red watery eye. The child would pace the floor with agitation due to the severity of the pain, so this is probably more likely to present to the emergency department. In the history, you should go on to ask about potential lifestyle triggers such as fluid intake, diet, caffeine, sleep, and screen time. Psychosocial stressors should be asked about. Has there been any difficulty at home or at school? In teenagers, you should never assume anything, so it's vital to ask about alcohol, smoking, drugs. Think about bullying, particularly online, and sexual relationships, keeping in mind safeguarding concerns. Although in general practice we are restricted by time, this part of the consultation is really important to take the time to do properly. Addressing the underlying triggers benefits the child not only in terms of the headache, but also their overall well-being. Moving on to examination, the focus is to rule out red flags or signs suggestive of a secondary cause. The child's weight and height should be measured and plotted on a growth chart, which should be interpreted with previous measurements to get an accurate assessment of the child's overall growth. If the child is less than 2 years old, then a head circumference and examination of head shape and fontanelles is also a vital aspect of the examination. A normal heart rate is reassuring, and if possible, blood pressure should be done to rule out hypertension as the cause of the headache. Depending on the history, you may want to do an ENT exam if you feel a headache could be referred pain. The success and detail of a neurological examination will vary depending on the child's age and, of course, the mood at the time of the consultation. However, a cranial nerve, neuromotor, and cerebellar examination should be attempted. It can be difficult to assess for papilledema in the GP setting, so I would always ask them to make an urgent optician appointment to get a full and more accurate eye assessment, including retinal photography. Hopefully, from the history and examination, you have ruled out red flags or secondary causes of headaches, and you can go on to address any concerns the family has and clearly explain your clinical diagnosis of a primary headache. The majority of your management may involve addressing lifestyle habits and psychosocial stressors. This requires motivation and commitment from the child and the family. Therefore, trust in the clinician's assessment and understanding of diagnosis is really important. Giving resources can provide a sense of control and autonomy when it comes to understanding and managing their symptoms. Some helpful websites may include Great Ormond Street, the Migraine Trust, and the Headache Relief Guide in particular is a really nice resource for families to use. Moving on to management. Once you have the family on board with your diagnosis, you can then talk about lifestyle management. The areas that you should cover can be remembered as the 4 Ds and the 4 S's. So the first D stands for diet. Encourage regular, healthy meals. Missed meals can be a trigger for headaches. Encouraging home-cooked and family sit-down meals is not only important for physical health, but it can allow a space for children to open up about school and other possible psychosocial triggers. Artificial flavorings and sweeteners can also trigger headaches, so encourage reducing highly processed foods. The second D is for drinks. Ensure that the child is getting enough fluid intake throughout the day. As well as the amount of fluid, it is important to ensure that caffeinated and sugary drinks are avoided. In terms of caffeine, it's not uncommon for quite young children to drink cups of tea, so you can suggest an alternative, such as a herbal or decaf tea. And then D for drugs. If medication overuse headache is suspected, then the analgesia should be stopped for at least 1 month. There may be a short period of 1 to 2 weeks when the headaches are aggravated before the headache improves, so it's worth warning families about this. And of course, alcohol, smoke, and recreational drugs should be avoided. Next D is for diary. A headache diary can be a really useful tool for children and families to increase the understanding of potential triggers, and it gives them some autonomy to manage these. The first S is for C, and this really is talking about an optician's check. Make sure they tell the optician at the appointment that this is for a headache, so a full check is done and retinal photography is included. Second S is for sleep. Sleep is not only important for alleviating headaches, but is also crucial for growth, development, concentration, and memory. Lack of sleep in combination with headaches can have a significant impact in school ability. Encourage families to meet the recommended hours of sleep for that child's age. And S for screens. We now have more information and evidence about the harmful effects of excessive screen time and social media on children. Harmful effects include reduced sleep, mental health, obesity, educational achievement, and many more. You'd be surprised how many hours a day children spend on screens, and families may not be aware of the harmful effects. The American Association of Pediatrics suggests limiting screen time to 2 hours per day for children over the age of 5, and less if they're younger. And the final S is for stressors. It is important to explore with the child the link between life stressors and physical symptoms such as headaches. Depending on the child's needs, you may want to involve the school, third sector support groups, online resources, and consider psychology or psychiatric referrals. So moving on to acute management, first-line medication for primary headaches is simple analgesia, such as paracetamol and or ibuprofen. For migraines, if this is not adequate, then a combination therapy of paracetamol or ibuprofen with a triptan is recommended. Triptan are most effective if taken as soon as the aura or headache begins. An antiemetic can also be considered for the acute management of migraines. It can be really helpful to make a management plan with your patient and write it down. That can then be shared with the school. The idea is to try and get on top of the headache quickly, reduce the length of the migraine, and minimise time out of school. For the majority of children, focusing on lifestyle habits, psychosocial needs, and acute pain management is likely to be sufficient. However, in a minority of children who continue to have regular headaches impacting their quality of life, despite this, prophylaxis should be considered. This may be the point at which you feel you've reached your limit as a GP. However, if you feel comfortable, then prophylactic medication can be started in the primary care setting. There is limited evidence of benefit for prophylaxis treatment in children, and this needs to be weighed up against the potential harms. Prophylactic medication should be reviewed after about 6 months to consider whether there is ongoing need for continued use. For migraines, propranolol is a reasonable first-line prophylaxis recommended by NICE for those older than 12 years old. It is licensed for this indication and has clear doses in the BMF. For chronic tension-type headaches, in 12 to 17-year-olds, NICE actually recommends considering a course of 6 to 10 sessions of acupuncture, cognitive behavioural therapy for relaxation techniques, or a 2 to 3 month trial of amitriptyline. Once you have a management plan in place, it is of course important to safety net and give clear worsening advice. This includes seeking appropriate medical advice if there is a change in the headache or they develop a new red flag symptom. So just to highlight some of the key points that we have discussed today. After ruling out red flags for secondary causes, taking the time to confidently reassure, explain the diagnosis of primary headache and signposts to useful resources may improve compliance and motivation to adhere to the management plan. Simple analgesia is first line for the acute management of primary headaches. Migraine-specific analgesia and antiemetics can be considered. Escalation of medication is not needed in the majority of cases. However, persisting headaches may require prophylactic medication or referral to secondary care. And lastly, most importantly, management should focus on adjusting and addressing the lifestyle and psychosocial aspects that are likely contributing to the headache. Thank you very much for listening to this podcast, and I hope it was relevant and beneficial to your future clinical practice and seeing children with headaches.